Hello friends. In the last video, we discussed symptoms and causes of Bell's palsy. In this video, we shall look at differential diagnosis of facial palsy versus Bell's palsy, assessment and treatment of Bell's palsy. Stick to the end as we will look at recent advances in the physiotherapy treatment of Bell's palsy, and I will provide you with reference books to refer for your examination. Subscribe the channel for more videos like this one. Now, let's start learning. So, how will you differentiate Bell's palsy from facial palsy? Well, it's easy. A patient with facial palsy will report a history of varicella-zoster virus infection, trauma which might be in the form of facial trauma or base skull fracture, stroke, or positive family history of multiple sclerosis. Whereas, a patient with Bell's palsy will have an idiopathic history, but patient may be diabetic or pregnant or may have an history of herpes zoster type 1 infection. As mentioned in this table, you may observe these clinical features to establish a diagnosis of Bell's or facial palsy. The most common feature is forehead wrinkling is present on both sides in facial palsy, whereas it is absent on the same side in Bell's palsy. Now let's differentiate facial palsy. To establish the diagnosis of herpes zoster oticus or Ramsay-Hunt syndrome, consider vesicles that appear on the skin of the ipsilateral ear pinna, external auditory canal, or skin below the pinna. Varicella-zoster virus is responsible for these vesicles, and it is seen in 10 to 15% of patients. In some of Bell's palsy patients, the eighth cranial nerve may also be infected, producing the symptoms of acute vertigo, deafness, and tinnitus. If your patient shows a bilateral facial palsy of lower motor neuron pattern, remember SGPT. S for sarcoidosis. G for Guillain-Barré syndrome. P for polio. T for tick bite or Lyme disease. Let's look at some other investigations you can consider in this case. EMG test. The severity and the extent of nerve involvement and the presence of nerve damage is determined. X-ray can help rule out infection or tumor. MRI/CT scan can eliminate other causes of pressure on the facial nerve. Now that you know about differential diagnosis, let's look at assessment for Bell's palsy. For the observation, see the drooping of corner of mouth, eyelids that don't close. In the examination portion, you must examine the sensory and motor supply of the nerve. For the motor examination, check the function of facial muscle by asking to perform these expressions. For the sensory examination, check taste of the anterior two-thirds of tongue. Another assessment component are scales. The one that is commonly used for assessing severity of Bell's palsy is House-Brackman Facial Nerve Scale, 1985. This scale assesses symmetry of face at rest, mouth, eyes, and forehead. Test and give grade accordingly. You may use it every week to know prognosis of the patient. Now let's discuss treatment of Bell's palsy. We shall look at three aspects of treatment: physiotherapy management, medical management, and lifestyle changes. We shall also discuss how you can determine prognosis of a Bell's palsy patient. Physiotherapy management. The first goal of physiotherapy management is to resolve the inflammation. If the patient comes immediately following the onset of paralysis, then he may be treated with either SWD or IR to increase the circulation in the stylomastoid foramen so that the inflammation can be resolved. If the paralysis is only due to compression or neuropraxia, then the patient will show a miraculous recovery once the inflammation is resolved and compression on the nerve is relieved. SWD and IR can be tried for a period of 1 week to 10 days. Ultrasound can be beneficial for acute Bell's palsy as it will reduce edema and provide normal healing environment. Next step in the physiotherapy management is maintenance of muscle properties. This can be achieved by using interrupted galvanic stimulation on the motor point of the paralyzed muscle. It has shown to improve motor recovery in patients with acute and chronic Bell's palsy. You can also opt for facial massage as part of physiotherapy. Massage is essential to maintain the circulation to the face as well as to keep the face supple. Remember that the direction of the manipulation used should be in upward direction and not downward direction. The clinical reasoning is that downward movements tend to stretch the paralyzed muscles more and can have a negative effect over the condition. Taping. These methods are used to decrease the facial asymmetry noticed in Bell's palsy. This is commonly used taping technique in the case of Bell's palsy. Re-education. Only if patient can tolerate sensory stimulus of faradic current to the face, faradic re-education is given. Other means of re-educating the movement is by using PNF techniques, visual feedback exercises, etc. The picture indicates exercises you can prescribe to your patient that he or she can do in front of a mirror. Kabat rehabilitation. These techniques are a type of motor control rehabilitation technique based on proprioceptive neuromuscular facilitation. During Kabat, therapist facilitates the voluntary contraction of the impaired muscle by applying a global stretching first and then giving resistance to the entire muscular section. Therapist then motivates voluntary muscle contraction by verbal input and manual contact. This is a new technique and has shown effective results in the rehabilitation of Bell's palsy. Prior to Kabat, eye stimulation is given to the specific muscular group so that we can increase its contractile power. Strengthening exercises. Once the facial muscles reach grade 3, then resistance can be given to muscle action to further strengthen them. Now let's discuss at medical management of Bell's palsy in short. If herpes simplex virus is suspected, acyclovir is prescribed for a week or so. However, for other infections such as varicella-zoster viral infection, other antiviral agents such as famciclovir or penciclovir or high-dose acyclovir are prescribed. Treatment with corticosteroids, prednisone, 60 mg/d orally for 3 days, tapering over the next 7 days, beginning within 5 days after the onset of palsy, is said to increase the proportion of patients who recover completely. It is believed that these drugs will lessen facial nerve edema, reduce nerve pressure, and prevent nerve ischemia. Lifestyle changes. Frequently the patient will have facial weakness such that he or she cannot fully close the eyelid, exposing the cornea to abrasions and drying. After applying ointment, these patients should tape their eyelid closed while sleeping. Occasionally it may be necessary to suture the lids partially together, a tarsorrhaphy, to protect the eye. A few patients will have aberrant regeneration of the facial nerve during recovery, leading to synkinesis. Synkinesis is defined as unintentional facial movements accompanying volitional facial movements. Mime therapy is proved beneficial for synkinesis. Now that you know physiotherapy management, let's see how you can determine prognosis of a Bell's palsy patient. Keep in mind that most patients recover completely without treatment, but this may take several days in some instances and several months in others. If there is incomplete paralysis of facial muscles, there is an excellent prognosis for full to satisfactory recovery that spontaneously occurs within 2 months. If the facial paralysis be complete, full to satisfactory recovery spontaneously occurs in about 80% of patients over 1 to 3 months. A poor prognosis for complete recovery is suggested by severe pain at onset and complete palsy when the patient is first seen. Even if recovery is incomplete, permanent disfigurement or some other complication affects only about 10% of patients. Recent advances. The recent advances in physiotherapy management of Bell's palsy is by using the electrotherapeutic modalities like neuromuscular retraining, NMT, Laser. Pulsed SWD. The articles mentioning these therapies are in the description box. And these are the book references you can use. Thank you for watching. In the next video, we shall look at stroke and physiotherapy management for stroke. If you have any questions, drop them in the comment section. I'd love to hear from you. Do not forget to like, share, and subscribe the channel.